Hi everyone. So welcome to the another session of the phacoemulsification. So here today I'll be showing you the problems that I have faced during this surgery. And initially the rhexis was small in this surgery, and then when I have placed the IOL, there was a cortical matter. So how I have removed that with the IA, and once I have finished the surgery, there was a AC collapse. So how I have managed that thing also, that also I'll show you in this video. So let's begin. Starting here, cleaning the fornices after 3-minute exposure of betadine drops. First, as usual, I will be going with the main port, and here you can see there is a good retro glow, so I don't have to use air dye wash, that I will skip. So once the main port is done, little support with the limbs, and then going inside for visco. Some surgeon even prefer to put the side port on the same time, but as I am learning like many of you, so I don't prefer that. I just put the main port and then I do my rhexis. Positioning of the eyeball is important, as retro glow depend on that. Problem still I face these days is that I remain scared of going to the periphery in a straight, so I prefer in the mid periphery, and then I started doing rhexis, and I will be doing the spiral rhexis that you will see. Almost finished. Now doing the spiral part. That's the complete rhexis, almost more than 6 mm here you can see. I'll be going for the side port now. Now time for the hydro dissection. Here you have to decompress the AC, the visco should be out, so that there is a space for the hydro to come out, else there is a chance of snap. And you go under the anterior margin of the capsule, and then you lift up and then you inject fluid, BSS, and you do same on the others 180-degree, and come to the center and tap the nucleus. If there is any doubt under the area under the main port, that you can do hydro from the side port also. I have done in some surgeries but not here. If possible some other day I'll show that thing also. So after hydro I'll be putting visco, and then it will be the time for dialing the lens. No editing has been done in this part of this video, so it is the my natural surgical time that you can see here. First I am trying in the clockwise manner, and there was some zonular tension, so then I tried in the anti-clockwise manner, and then I was succeeded to dial the lens. As a trainee surgeon you will face a lot of problem, like here I am struggling to fix the phaco probe. The sleeve was not properly placed, so I had to check the flow. So when you do surgeries initial days you will face this kind of that issues, and I still struggle with those things. And now I'm going with the chopper. So there are a lot of loose cortex that I'll be taking out first. You have to remember the margin of your rhexis, as dye has not been used, so sometimes it may turn difficult to identify the rhexis margin. So that time there is a chance of tearing the rhexis margin. So you have to be very careful and you have to remember. And instrumentation also you have to be careful while going for to the periphery for direct job. Had some issues with the vacuum of the phaco machine, and so I was not able to hold the lens, so I had to change it. I had to change the phaco setting. Initial half was done, but that was not completely retouched, and complete 2 quadrant was not achieved. Anyway, I was asking for a change of the chopper, but I didn't get it, so I will refill the AC with visco, and then I will be proceed for the surgery again. So this is how the separation was done. Now with the help of a dialer, trying to take out one quadrant, but could not do that, and so I am moving the lens, and we'll try to do the same on the different quadrant. During the surgery, whenever there is any doubt or whenever you suspect the PC rent, just come out and put visco and check. On the initial days of the surgery, there is no point of taking any risk, and putting visco and coming out or taking interval between the surgeries, and there is no harm and nothing to be ashamed of that. As a trainee, the more surgical time is expected from all of us. Now just going to the periphery to hold the quadrant, the nucleus part, and getting them into center. I have a nuclear support here, so thus I am safe from holding the posterior capsule. This is the last piece. So as usual, I earlier also in my another video I have mentioned there is the time when we should go slow, and very gentle. We have to take care of the PC as that there is no support now. So the phaco part is done. Now I'll put visco and we'll check for any rent or anything. So whatever we can see is cortex and the fold on PC. In between I have injected diluted adrenaline also, as the iris was the pupil size was reducing. Now going with the coaxial. Initially I tried to hold the cortex that lies under the main port, and with the coaxial that is the most difficult thing, removing the cortex under the main port. Otherwise I find coaxial better over bimanual. Here you go to the periphery, hold at the 2.5 or 2, and then it bring it to the center, and then go to the full aspiration. Going to the periphery, holding and bringing it to the center. And once it is detached from the PC, then push the foot pedal completely. Now again trying for cortex under the main port. And that's a big chunk of cortex. So the IA is done. Now going with visco again to inflate the bag, and now it is time for the IOL. It's a trifocal IOL with 4 haptic. So the leading two haptic first go under the rhexis margin, and I'll be using dialer, holding the not completely injected the IOL. As you can see, the trailing haptics are not opened up, and then immediately I just push and use the dialer to send it under the rhexis margin. That's your IOL is in the bag. Now it's time for the visco removal. So while doing the visco removal, from nowhere a cortical matter came up. I was trying with the full aspiration, but then it didn't work. So I had to go with dialer. You will see now how I have managed this. You just hit and push the cortical matter So my surgery is almost done. Now AC is fully there, but now that's the problem where I was hydrating the port, the air came out and AC collapsed. I tried injecting air again, but that didn't work. I expect some radius of thrust, so I have loosened the speculum, but still that didn't work. The IOL was tilted. Then I tried to reposition it with the dialer, so that was not a correct step. And then I tried at the same position, I tried to inflate with air again. But air was not staying in AC. So again I have injected air and it is not staying in AC. So I will be using hydro to fill the AC and to port the side ports and main port. So first hydrating the main port, and then refilling the AC, and now you can see that the IOL have in position in the bag and AC is formed and the air bubble is moving. So now hydrating the side port. More air, and then hydrating the side port. So as trainee surgeon we do a bit more port hydration compared to the faculty, so might be that is the reason that I am also doing, though these ports were hydrated earlier. There was no requirement of going again, and now AC is formed. It's time for subcunch, and then your case is done. So if you have liked this video, the steps, though it is a complete kind of unedited video, so it took some more time to show you. So if you have liked, just hit the like button and subscribe to my channel. Thank you.